Michael Woodward, who is a geriatrician, head of aged care research at Austin Health, is going to talk to us about RSV in older people. Michael, thank you.
Okay, unfortunately I've only got less than half of my time, so I'll be as quick as I can because I know you all have to get away. Of course, older adults are not as important as mothers and children, I understand that. So I'll talk a little bit about RSV. I think we know it's a contagious seasonal virus. It co-circulates with other viruses. There's two groups, RSV A and B. It's transmitted by inhalation or contact with respiratory excretions. It can usually last for about 3 to 8 days, but longer in people who have a weakened immune system. There are seasonal epidemics, less so in our northern regions and less so with travelling and people escaping heavy rain in the northern regions during the rainy season coming south. The reproduction number is about 3. Most of you will be aware that we try to get reproduction numbers down below 1 to get rid of epidemics. It's certainly higher than some of the other commonly circulating viruses, as shown here. Mainly a disease of seasonality during the autumn and winter regions in the south, but less so up in the north, and as I said, affected also by travel and by escaping the north during the rainy season and coming south. It's a disease of all ages. We've heard a lot about its terrible impact on infants, but infants generally survive. Older people, however, also get RSV because immunity is not lifelong. Most people have several episodes of RSV throughout their life. Of course, vaccination of mothers and treatment of young infants will prevent that, we would hope. The signs are usually simply a respiratory infection, cold-like symptoms, but it can lead to serious conditions including pneumonia, worsening of underlying chronic lung disease, new cardiac or lung disease, hospitalisation, ICU admission and death. Testing has increased for a number of reasons, one of which is now a reportable disease, but there's a lot more awareness of RSV, driven, I think, largely by awareness of coronavirus. So you can see that the numbers have increased, partly through increased testing. But if we look at 2023, where there was good testing in 2024, and that's not a full year in 2024, the numbers are definitely going up. You can see that here. This is the latest data that I got right up until 15th of December 2024, again showing the seasonality and showing the slightly larger numbers in 24 than 23. There was an aberration post-COVID when, as we all came out of lockdown and threw away our masks, there was a non-seasonal RSV peak, but that's now back to its normal seasonality. And these are notifications on the right in those over 60. You'll see that it's very similar to influenza in terms of seasonality. Not quite as high a peak, but a very significant number of people affected by RSV in the winter months, and not that dissimilar from the numbers affected by flu. And in fact, they carry similar risks. The hospitalisation risk ratio and the mortality risk ratio, with one meaning flu is the same as RSV, are pretty similar. You could argue, in fact, that the mortality ratio is, the mortality risk is about 19% greater, but the important thing is a very similar risk with the two common viruses. Who's at most risk? Those people who have chronic illnesses, as listed on the right there, are at most risk. And these are the illnesses that can be exacerbated or indeed newly caused by RSV infection. Basically, you're more likely to be in hospital and you're more likely to stay for a longer time. These are the risks of hospitalisation for those with and without certain common chronic illnesses, the blue being those without, the orange being those with. And if you look just at the older age group, that's the second of each of the pairs of bars, you'll see that there's a far greater risk of being hospitalised if you've got chronic airways disease, asthma, chronic heart disease, kidney disease, diabetes, etc., than if you don't have those conditions. In fact, the risk of being hospitalised is nearly 10 times as high for some of those chronic conditions. This is reflected in this curve here, which shows the risk of hospitalisation is exponentially greater in those over 65 and going up, although that might be a reporting issue. Basically, you're 6 times more likely to be hospitalised if you're over 65 than if you're between 5 and 64. Of course, there's a very high risk in those under 5. That's not shown on this graph here. And the length of hospitalisation is about 6 times if you're older compared to 3 days if you're younger, 6 days if you're older. And whilst younger people, those under 65, account for 97% of all hospitalisations, and this is going down to age 0, they only account for 41% of mortality, whereas older people, 3% of hospitalisations, but 59% of the mortality. And again, most of that 97%, of course, is infants. So basically, you're more likely to stay for a longer time. If you're an older person with RSV, you're more likely to develop pneumonia, be admitted to ICU, to have exacerbations, or indeed to die. And unfortunately, the survival rate after admission to hospital is lower than with influenza. 81% will be alive at 12 months after flu, only 74% with RSV in this study. So therefore, there's a rationale for RSV vaccination. There's no specific oral antiviral agent. There's obviously monoclonal antibodies. They're not recommended for older people. Treatment is supportive. Burden of disease in terms of hospitalisations is significant, so vaccination is the way to go. Now, as we've just heard, unfortunately, there's a bad history of vaccination. This is a slightly different paper to the one we've just seen in the last talk, but it shows the same thing. So in a randomised trial of RSV versus para-influenza vaccination, the RSV, which was in this case a formalin inactivated whole virus vaccine, did cause a rise in neutralising antibodies. But when RSV became prevalent in the community, the rate of infection in infants who had received the vaccine was not remarkably different, so it wasn't protective of infection, but it caused a far greater risk of hospitalisation and death in those who were vaccinated. And that basically ended any interest in RSV vaccination, simply because we didn't understand enough about making a smart vaccine. Subsequent investigations have suggested that the vaccine had amplified the T-cell mediated responses and non-neutralising antibodies, which actually enhanced disease severity. So we've learned a lot about childhood vaccination. That's the iceberg on the left, but there's still an awful lot we don't know about vaccination of older people. We don't know about long-term frailty and functional decline, etc. We're learning, but the clue to better getting data on vaccination is to work out what to vaccinate against, and it's the pre-fusion protein that we've just seen. It changes when it fuses with the cell. It's too late to develop an antibody against the post-fusion protein, although it might have some benefit, but it's much better to go for the pre-fusion protein to stop the virus fusing with the cell and forming the syncytium that gives it its name. The 2 vaccines that are available in Australia, there is a Moderna one which is being developed, as shown here. You'll see that they had TGA approval at similar times. The one on the left is monovalent but adjuvanted. The one on the right is bivalent, non-adjuvanted. And they're both at this stage available single script only, and they're registered for 60 and over for the prevention of lower respiratory tract disease and clearly hospitalisation and death caused by RSV. The GSK one is shown on the left. It uses the AS01 antigen, adjuvant I should say, which is also the same one as in Shingrix, but in half the dose. And the reason for adjuvanting a vaccine is to improve the immunogenicity and to overcome immunosenescence. There's now 3-season data with the GSK vaccine. I'll go through it step by step. I'll move fairly quickly through this. Some of this data is a little overlapping. Basically, though, in the first season, the vaccine efficacy was very acceptable, 82.6%. 7 cases in the vaccinated versus 40 in the placebo group, with about 12,000 in each arm. It did cause a significant reactogenicity. If you look at, say, pain in the injection site, 60% compared to only about 10% in the placebo group. And I'll just keep that in mind when we come to the data with the other vaccine. It also showed efficacy over 3 seasons, so up to 30 months, 3 seasons. In the primary endpoint, it was 62.9% effective, again, very acceptable. It was also similarly effective against some of the other respiratory endpoints over 3 flu seasons. And if you look at it season by season, I think with the eye of perhaps faith, the middle line, which is the primary endpoint, the purple line, it doesn't seem to be waning much between season 2 and season 3. Now, in the trial, they did try giving a second dose of the vaccine for season 2, and it did not increase protectiveness. So you only needed to give the one dose, and it seems that it's probably losing most of its effectiveness between season 1 and season 2, and maybe it's being maintained beyond season 3, but we're not going to get that data. It seems to work just as well in those who are older, those who are pre-frail. There weren't enough people in the frail group. Those with comorbidities, in fact, older age and pre-frailty seem to give you a greater efficacy over the 3 seasons, somewhat counterintuitively. If you look at the efficacy in each of the 3 seasons individually, we've got the 82.6 for season 1, 56% effective in season 2, and 48% effective in season 3 alone. So this is a summary of all those endpoints. Essentially a very effective vaccine, probably due to its adjuvant, and the serious adverse events were very acceptable, basically the same in both the placebo and the treatment group, and there were no cases of Guillain-Barré or acute disseminated encephalomyelitis, but of course these relatively small studies don't give you that data. You need phase 4 millions of patient data to fully establish that. The Pfizer vaccine, which is unadjuvanted, bivalent, has been looked at only over 2 seasons. This is the season 1 data against 2 of the endpoints, and essentially very effective. Efficacy about 70 to 80% against either 2 or 3 or more respiratory symptoms. So an effective vaccine. Now that's a little counterintuitive because it's not adjuvanted, and even I can't understand that. I'm told by Pfizer they did try using alum, a very simple adjuvant, in their preclinical work, and it didn't increase the immunogenicity of the bivalent antigen vaccine. So that's interesting. But it does reduce side effects if you don't have an adjuvant. So if you look at pain and injection site, I said it was 60% with the GSK vaccine. It's about 10% only with this vaccine. So it's less likely to cause local reactions, but people are not that put off by significant local reactions, as we're seeing with Shingrix and COVID and even Fluad, the last 2 being adjuvanted vaccines. So this is the efficacy for the Pfizer vaccine over 2 seasons. It's not, again, falling off that much between season 1 and season 2 with any of the 3 endpoints that you can see there, either 2 or more symptoms, 3 or more symptoms, or any acute respiratory infection associated with RSV. So the recommendation in the Australian Immunisation Handbook is that it be given to all Australians 75 and over, or 60 and over if you're Aboriginal Torres Strait Islander, and over 60 if you have other medical risk factors for severe RSV complications should you develop the infection. It can be considered for others with the TGA, within the TGA registration. But the latest news that's only just off the press is that the Pfizer vaccine has now PBAC approval for all 75 and over and 60 to 74 Aboriginal Torres Strait Islander. This should translate it to its listing on the NIP in the near future. So, drum roll, the Pfizer vaccine should be available on the NIP for adults 75 and over once prices and minor things like that have been negotiated. There's also a need to vaccinate travellers for all sorts of reasons, not just travellers to Northern Australia, but travellers to anywhere outside of Australia. And I think that discussion should be had with all our patients over the age of 60, for which it has registration. Co-administration, the guidebook says it can be given. I personally have some concerns about giving 2 adjuvanted vaccines. The one that concerns me the most is Fluad Quad with one of the AS01 adjuvanted vaccines, either Shingrix or RSV. But there's no reason for not doing it. You just have to warn the patient that they're likely to get side effects, local side effects, and shouldn't stop it. I mean, you'd argue that if you've got two arms in front of you, give 2 vaccines rather than ask them to come back in 2 weeks. So there is a rationale for giving 2 vaccines of any combination, including RSV, but just be aware of side effects. So here are some resources. I just want to emphasise the role of the specialists. We had a vaccination class, a master class held very close to where we are now in November, where we had a number of young specialists. We particularly targeted them to try and get them more interested. I know some groups, cardiologists, gastroenterologists, rheumatologists have spoken about vaccination to their patients quite extensively for years now, but many specialists aren't having that conversation, even though in the case of geriatrics we get funded quite nicely for a comprehensive geriatric assessment where we must talk about vaccination. We can drive vaccination rates back up again, specialists, if we're well aware of the benefits of vaccination. So I think a specialist can set policy within residential care, can write scripts, can liaise with the GP. In the hospital they can recommend vaccination and make sure, even give it in the arm. And in the community, we should have that discussion with our patients in our letter back to the referring doctor, usually a GP, and we can even provide a script for veterans on the spot if we want to. We can also give it to non-veterans, but I think that's best done by the GP. But I give quite a few of my elderly patients a DVA-approved script, and they go across the road and get vaccinated within 10 minutes in some cases. So I thank you for listening. I hope we've made up a little bit of the time. Thank you.